Hello everyone, this is Dr. Akhil Shah, Professor of Skin and VD. Today I am going to discuss a topic which is an infestation of scabies and pediculosis. Now scabies, let's start with scabies first. Scabies is a very common public health problem which is affecting 100 million persons annually, and it is a highly contagious ectoparasitic infestation of skin by a human itch mite, which is called biological name is Sarcoptes scabies var. Hominis, which belongs to the suborder of Astigmata and the family of Sarcoptesi. Predominantly, scabies is a disease of children which affects the people of all races and social classes worldwide. The exact incidence of the disease is not known, which varies from time to time, but the highest prevalence has been seen in children who are aged less than 2 years of age. Now, what are the risk factors? High humidity, low temperature, which is seen in tropical and subtropical countries. India is a subtropical or tropical country. Overcrowding, already seen in developing nations. Poor hygiene, which is more common in poor people. Homelessness, poor nutritional status. If there's an infested member in the family or the sexual partner, the chances of getting scabies becomes more. It is more common in some seasons, which is winter and autumn, other seasons where scabies is more prevalently seen. Let's see the life cycle and morphology of the mite. The mite is a whitish hemispherical mite. The female mite is bigger than the male. Female measures 0.4 millimeters to 0.3 millimeters, where the male is just 0.2 by 0.15 millimeter. The female mite is the main causative agent. It crawls on the skin at the rate of 2.5 centimeters per minute. And warm skin is preferable because in warm skin, it crawls better and for a longer period of time. Now, only if the fertilized female can burrow into the skin. Burrowing is the cause where how it can stay in the skin. Now it burrows through stratum corneum up to the malphigian layer at the rate of 0.5 to 5 millimeters per day. There it lays about 150 to 180 eggs in its lifetime. Now after laying eggs, it dies in about 30 days. Now the egg becomes larva, then it becomes a nymph, then it undergoes 3 moltings. The nymph undergoes 3 moltings and then becomes a mature mite. Then where does it occur? It occurs on certain specific areas of skin. On the face, not very commonly seen because there is high density of hair follicles and sebum, which is a hindrance to its colonization. Now, a healthy male harbors around 10 to 12 mites. A maximum of 50 mites can be seen in immunocompromised female persons. Now, there's an entity called Norwegian Scabies, where it can go up to 2 million mites in a person. Imagine. The mite lives till 1 to 2 months in a person, but outside the body, it cannot survive more. It just stays for 1 to 2 months in a person, but outside the body, 1 to 2 days. If exposed to temperature more than 50, the mite dies in 10 minutes. So autumn and winter are more suited. How does it transmit? It transmits from close person-to-person contact. Even if their contact is only for 15-10 minutes, then it spreads. Occasionally through fomites like bedding or clothing. In adults, scabies is frequently sexually transmitted. Now, it cannot be transmitted by pets or animals. The incubation period of the disease is 3 weeks. In case of reinfestation, it can occur in 1 to 3 days only. There's intense itching. The characteristic of the itching of scabies, it is predominant at night. In the day, it is there, but it is persistent and tolerable. In the night, it becomes intolerable. What are the signs? How do you diagnose it? The morphologically, there are pruritic papillovesicular lesions, excoriations, and classically burrows at some specific sites. What is a burrow? Burrow is the pathognomic sign of scabies. It's a serpentine thread-like grayish or dark line, approximately 5 millimeter long, It is found in places, I told you, some places it is commonly seen where the stratum corneum is thin, it is commonly located. What are the sites? Predominantly involves finger webs. The skin is thin there. Wrist, axillae, areola, umbilicus, lower abdomen, genitalia, and buttocks. Now these parts of the body form an imaginary circle, which was named by a very famous physicist, dermatologist called Hebra. It is called circle of Hebra. In adults, it usually spares the face and scalp. So below the knee, the problem is there. But in infants, even the entire skin is involved, even the face and scalp. There are many types of scabies. Scabies of the child, nodular scabies, scabies with bullae called bulla scabies, gentleman scabies or scabies in clean, where there is no lesion and people of white collar jobs and very clean people, but still they get scabies. It is called scabies in clean. There is something called crusted scabies, which I've already discussed, has 2 million mites in a person. Called Norwegian scabies, very commonly seen in immunocompromised, HIV infected patients, vagabond people, homeless people, possible in those people where hygiene level is poor, immunity is lower. Now there's called something called scabies incognito, where steroids have been applied or some drugs have been applied. There is an animal transmitted scabies also. A picture of Norwegian scabies, you can see crusted plaques all over the body. These will contain lots and lots of mice. Nodular scabies classically seen on the scrotum. You can see penis and scrotum have multiple well-defined nodules, which are extremely itchy. Complications. What complications can occur with scabies? A lot of itching can cause ulcerations. Ulceration is denudation of the skin. Stratum corneum is removed. The whole skin is removed. Ulcerations happen. Erosions happen. Ulceration can lead to secondary impregnisation. Impregnation is colonization of bacteria secondarily over the itchy part or the scratched part. That is due to scratching. Scratching is intense. It does not subside till you remove the stratum corneum. Then impregnation is secondary. There can be overlying secondary bacterial infection on the lesions. Ulcerations can turn into ecthyma, can turn into bullous impetigo. Sometimes the streptococcal colonization can reach your kidneys. It can cause streptococcal glomerulonephritis, though it is very rare, but possible. Sometimes leukocytic cytoclastic vasculitis or something called a small vessel vasculitis can also occur, wherein infection of the blood vessel endothelium is involved. Classically see a patient, this is when fingers, the web spaces are involved, crusting is there, but there are multiple fluid-filled vesicles, pustules in rather. This is a classical case of scabies with secondary eczematization. How do you diagnose? How do you know that the patient is scabitic? Usually, there's no specific diagnostic tests, and it is mainly diagnosed clinically. But if you're hell-bent on diagnosis and you want to show the causative agent, you can demonstrate the egg, the scabella or the waste product or the mite as such under microscope. Serological tests are available, but they have less than 50% accuracy. Specific IgE antibody demonstration or quantification to a major scabies antigen recombinant RSARS43 is a test which is highly sensitive. PCR immunosorbent assays can be done. Dermatoscopy is another method how you can demonstrate the mite or demonstrate the scabella or egg. These are the tests or these are the specific methods how you can demonstrate the egg. Demonstration of egg is the only essential part. Once you demonstrate it is due to the mite and you know it is scabies. This is the mite and seen under microscope. It is a structure, it is a rounded structure with 6 legs and classically seen like this. And sometimes it's moving. You can use the fun when it moves. You can see how it crawls. These are the scabula or the waste products or fecal products of the, sometimes called fecal products of the scabies mite. These are seen like this. If you demonstrate this, there's a lot of the itching is due to these parts, these things only. How do you know it is only? If you're doubtful about the diagnosis, what other things can be possible? In a classical scabies case, insect bite reaction, Pomphylix or dyshidrotic eczema can be there. Atopic dermatitis can be confused. Dermatitis herpetiformis is a classical thing which is an itchy excoriation seen, but specific sites. It also has sites. There's something called neurotic excoriations where the cause is not known, but the mental condition of the patient leads to excoriations, and excoriations look like scabies from outside. Infantile scabies, when it happens in infants, infantile acropustulosis is a diagnosis which is similar or mimicking the scabitic lesions. Eczema herpeticum or a viral infection, which is seen in atopic dermatitis kids, children, confuses. Papilla urticaria, highly itchy condition, does also confuses us with scabies. Viral exanthems can be sometimes mistaken for scabies. Now, the bad form of crusted scabies, most common differential diagnosis is erythroderma due to psoriasis. Scabies, mind you, can cause erythroderma. The whole body can be involved. Looks like scabies, looks like psoriasis. Seborrheic dermatitis can be confused with scabies. Darier's disease and a cantholitic disease, specific disease can be confused. A lot of eczemas, endogenous, exogenous eczemas can be confused with crusted scabies. Erythroderma, as I said, then the 90% of body surface area is involved. Crusted scabies can lead to that erythroderma also. Nodules, when you see on specific sites, arthropods bites can show like that. Pseudolymphomas, many pseudolymphomas can look like nodular scabies. Identity called histiocytosis X can also mimic. Specifically, juvenile xanthogranuloma does look like nodular scabies. Now, how do you treat scabies? Now, treating scabies, we treat the patient along with everyone who lives with him. Every patient, every family member who is in close contact with the scabies patient has to be treated. Otherwise, it becomes a ping pong infection. You treat one person, the other gets infected. You treat the other person, the first gets infected. Unless and until every patient or the close contact of the patient or the family is treated with an anti-scabitic drug, none of the patient gets okay. They keep coming to you back and back with the same complaints. That the itching is not going, it is again recurring. The itching is not going, again reoccurring. So treat each and every person of the family who lives, sleeps, or stays with the infected person. As I told you, adult scabies can be sexually transmitted. So the recent most sexual partner with whom the patient has had sexual relationship should be treated because he or she can be the source. The topical applications, many topical applications are available, which has an anti-scabitic drug called permethrin, most commonly used, should be applied on the whole body in adults. I'm saying in adults below the neck, the whole body should be applied. The whole 30-gram tube, now it's available in 60 also. The whole tube should be applied all over the body, particularly on the sides of the circle of Hebra. First, clean and dry the skin, take a bath, take a shower, make your skin warm so that the mite comes out. Then apply the anti-scabitic and rub it so that the mite comes in contact with the drug and dies or gets paralyzed. Now, in infants and children, as I said, scalp and face are also involved. So you should include application of anti-scabitics on the face and scalp as well. All the clothes which were worn by the patient, the bed sheet on which he sleeps, the pillow cover, and the bed linen should be washed at a very high temperature in a hot boiling water, ideally, and sun dried in the morning so that no mite escapes. Avoid touching the mucosa. Once you've done all this, report to your doctor. After 1 week, the doctor decides whether to give another application of the same drug or to stop. Depends on how your itching is there, how your uh, condition is. So doctor has to decide after a week whether it should be continued or not to be continued. What are topical therapies available? As I told you, the best drug is 5% of permethrin. It is the drug of choice at present, most widely used, safest, even in children as young as 2 months old, and pregnant women. Everybody can use permethrin. It has to be applied overnight. The whole tube or the whole cream of the pack of 30 grams has to be applied overnight, 12 hours minimum. Repeat the application after 10 days. It has a cure rate of 89 to 100, which is very good. But it has insignificant, not significant, irritant potential adverse effects. Mechanism of action, how does it work? It disables the nerve cell transport channel and hence paralyzes the mind. So spastic paralysis occurs. Another old application was GBHC or Linde. It is proper and safe when you apply properly. Gives a cure rate of around 89%, which is lower than permethrin. In infants and children, the application should be restricted only to 2 hours because it is neurotoxic. Repeat application after 1 week. But the Linden is a pregnancy category B drug, so should not be used. So in infants and children, not much safe. Pregnancy, not much safe. So in short, it ranks below permethrin. How does it act? It acts on the central nervous system, leading to increased excitability, convulsion, and death. So it is a rather unsafe drug. Benzyl benzoate used to be used earlier. 25% of solution of benzyl benzoate used to be applied for 3 continuous nights. It is irritating to raw areas and eyes. It has to be applied below neck 3 times within 24 hours without intervening bath. So three times, but has a very low cure rate, 10 to 12.5% only. Can be used in children. Glutamitone 10% has lower cure rate and low irritation potential. Good antibiotic action. It is an antibiotic agent as well. To be applied twice daily for 5 consecutive nights. But it is not approved for use in children. Pregnancy category C. Not useful as such. Ivermectin is a wonder drug which has come when after its discovery and use in pediculosis and scabies, it has been a wonder drug. In a dose of 0.8% weight to volume, ivermectin solution is applied overnight, single application, repeated after 5 days. It is not safe in children less than 5 years old with pregnancy. So, top choice is permethrin. Respiratory sulfur, 5-10%. Relatively safe for infants and pregnant women. 3 consecutive applications required. Has unpleasant odor and staining property. But it is used in mass applications where whole schools, whole communities are itching or has scabies. Respiratory sulfur has been known to be used for lot of people. It is the oldest scabitic, not much used now. Systemic therapy, the drug of choice for systemic therapy is ivermectin. It has been used since 1987 for other parasitic infestations like strongyloids or onchocerciasis. It is a derivative of microcyclic lactones. It induces parasite paralysis by blocking glutamate-gated chloride channel. Safety is not established in children below 15 years and pregnant women. The dose is 200 microgram per kilogram per dose to be dosed exactly 2 weeks apart. It is sometimes neurotoxic, but not much evidence has been found. Two doses are required. What's the bone treatment? Antihistamines will be required for 2-3 weeks oral. Emollient and soothing agents like calamine to take care of the itchy part. Topical intralesional steroid for persistent nodular lesions. Sometimes, rarely, topical and systemic steroids are required for allergic manifestations of the disease. Crusted scabies, same treatment as ordinary scabies, but to be repeated many, many times because there are many mites are there. Thick hyperkeratotic crusted plaques to be removed by keratolytic agents like 5-10% salicylic acid, 40% urea, or by soaking in warm water. Systemic therapy should be given along with topical refractory cases. Methotrexate has been used. Nails should be cut short and brushed with anti-scabitic agent. Animal scabies is self-limiting. Animal should be adequately treated, not the person. Treat the animal. Systemic antibiotics, so secondary pyodermas. Use non-irritant, non-toxic antibacterial agents like cetrimide, chlorhexidine. Simultaneous treatment of all contact should be done, even if they are asymptomatic. Avoid direct contact to skin, that skin to skin contact. Wash the bedding, wash the clothing. Room should be thoroughly cleaned. Close contact should be avoided. Environmental disinfection. Now that goes about scabies. There's another infestation which is also a scourge in the society. It is called lice or pediculosis. How does the lice infest the human beings? There are 3 specific varieties or species of humans that affect the humans. One is Pediculus humanus capitis, which is called head louse, Pediculus humanus corporis, which is body louse, and Thyraesis pubis, which is called pubic or crab louse. Now, head louse affects the scalp hair, more common in children, age of 3 to 11 years. Head-to-head contact, sharing combs, brushes, and hats leads to the disease. A lot of other ways like clothes, seams of the clothes, poor hygiene, unsanitary conditions lead to the infestation. Pubic louse affects the pubic and axillary hairs. Also, specifically, it affects other parts of the body like scalp, eyebrows, and eyelashes, other hairy areas. Because it is a hair. It is, although the head louse does not affect the body, pubic louse affects the body. Intimate contact, sexual intercourse, and shared clothes are the other causes. Body and head louse are similar, long and slender. Pubic louse is short and stout with wide body resembling a crab. 3 pairs of short jointed legs, but it requires blood for survival. Cannot survive away from host. It has to stay on the host. Female lays 6 eggs or nits each day. Incubation period is 30 days. Pediculosis capitis or head louse. Itching and secondary pyoderma are the presenting manifestations. Erythema and intensely pruritic papules on the scalp. Nits attached to the hair shafts. Favored site is behind the ears and occipital region. Cervical lymphadenopathy is common in children. Body louse, itchy papules and scoriations on the body. It's a part of vagabond disease. It lays the eggs or nits in seams of clothing or folds of clothing. Pubic louse, lice and nits are seen in patient or family members attached to the base of the hairs. Maculae cerulae or slate-colored macules resulting from intracutaneous hemorrhages is common with pubic louse. Demonstration of black speck-like body attached to root of hair at an angle is classically of pubic louse. See, this is the photograph of head louse. The other one is a vagabond disease. How do you treat? Treatment of pediculosis is of malathion, 0.5% malathion, 12 to be kept for 12 hours, repeat after 7 days. Carbaryl lotion, 24-hour application. Carbaryl shampoo, 3 to 4 minutes application to be repeated after 7 days. Gamma benzene hexachloride, 1% lotion, 12 hours application. Shampoo, 4 to 10 minutes application. 2 applications to be repeated after 7 days. Permethrin. Most importantly, the permethrin lotion has to get overnight for 8 to 12 hours. The permethrin rinse has to be kept for 10 minutes to be repeated after 7 days. Which are the pediculosides or the drugs which are anti-pediculosidal? Permethrin 1% lotion or shampoo is the first line treatment. Pyrethrin 0.3%. Pipronyl butoxide 4% shampoo. Malathion 0.5% lotion. Spinosad 0.9% suspension. Benzyl alcohol 5% lotion. dimethicone solution, ivermectin solution, and oral ivermectin. What are the additional recommendations? Pediculosis corporis, for pediculosis corporis, only washing and rinsing or clothes in hot water followed by hot ironing of the seams is required. Repeated application of petrolatum on eyelashes and eyebrows. Remove the lice with tweezers. Contacts should be checked and treated. Combs, hairbrushes, and clothes should not be shared. So that concludes scabies and pediculosis. I hope you learned a lot about these two dreaded diseases, which seemingly don't look like something very troubling. Once it sets in, the whole families are involved. I've seen little children pediculosis suffer so much, cannot study in school, lead to anemia. Scabies people itching a lot, self-esteem is low, cannot sleep at night, day work in the day is affected. So care should be taken to treat these two diseases carefully because the treatment is easy. Treatment is pretty easy. Easy treatment and good results. So that concludes the discussion about parasites of the skin, infestation of the skin, most of scabies and pediculosis. I thank you all. Hope it gives you an insight into these two dreaded diseases. Thank you so much. Stop.